Clinical Cytogenetics, Common Autosomal Trisomies, Module 2, Lecture 1. Autosomal aneuploidy syndromes. Common syndromes include trisomy 21 or Down syndrome, trisomy 13 or Pateau syndrome, trisomy 18 or Edwards syndrome, 4P- or Wolff-Hirschhorn, and 5P- Credichet. Down syndrome was first described by Dr. Langdon Downs, and the word syndrome just means a number of features put together. The original syndrome was described in 1850, but it wasn't until 1959 that we realized that children that had the clinical phenotype of Down syndrome actually had an additional copy of chromosome 21. We are still not certain why that extra chromosome causes the clinical phenotypes that it does. The majority of children with Down syndrome have non-disjunction that results in an additional copy of 21 in all the cells in the body. Approximately 2 to 4% are mosaic. When the egg and sperm get together, they divide about 4 times. At the 16-cell stage, 3 cells become the baby, and the other 13 become the placenta and the membranes and whatnot. If that additional copy of 21 was lost prior to that point, nature is pretty good at taking the 3 cells that are normal, and it's actually possible the placenta could have trisomy 13 and the baby could actually be normal. But if it happened after the 16-cell stage, for instance, at the 32 or 48-cell stage, if that additional copy was lost in some of the cells, then some of the cells in the baby would have normal chromosomes because the extra copy of 21 was lost, while the others had plus 21. Unless it's less than 5 to 10%, it doesn't have significant change in the clinical phenotype, because when we're looking at blood or skin, we're still not certain what the percentage would be, for instance, in the brain. And then finally, translocation. The chromosome is attached to another chromosome, which we'll be describing a little bit further when we're talking more about cytogenetics. Families often, when they have a child with Down syndrome, they get on the internet and they'll say there's 3 types of Down syndrome. There's not 3 types of Down syndrome. There's one Down syndrome, and it just has some different causes. Both of these, the first 2 causes, are caused by non-disjunction, and the third is a translocation. The clinical phenotype, whether it's a translocation or not, is not different at all. Low-level mosaic might have a milder phenotype. So here we have an example of a Robertsonian translocation. Here's our 14 and 21 that are separate, and they undergo meiosis, and one parent, they give 1 copy of 14 and 1 and 21. But here we have a 14, a 21, and a 14, 21. And so if this parent donates this copy, then there's 1 copy, 2, 3 copies of 21, and this can result in Down syndrome. The risk of having a child with Down syndrome increases with increasing maternal age. It really kind of takes off after the age of 40. This is at amniocentesis, and this is at birth. Only about 60% of babies with Down syndrome actually make it to term. Down syndrome occurs in about 1 in 500 to 1 in 800 live births. 4,000 to 5,000 children are born with Down syndrome every year, and 250,000 families are affected. Women under the age of 35 give birth to 80% of children with Down syndrome. So even though a woman's individual risk increases as she gets older, the vast majority of babies born are born to women under the age of 35. As the woman gets older, the risk of having a baby with a chromosomal abnormality increases. Diagnostic testing, so you can see here on this table, at the age of 29, the risk of having a baby with Down syndrome is about 1 in 1258, about 1 in 476 of any chromosomal problem. At the age of 34, it's about 1 in 441, 1 in 244 of anything. And then at 35, it increases to 1 in 179. But really, the risk of having a baby with a chromosomal abnormality really starts taking off in the late 30s. Diagnostic testing, such as amniocentesis and craniophilia, can determine if the baby is affected. Non-invasive testing is becoming more and more useful. Prenatal signs of Down syndrome, looking at ultrasound, include a thickened nuchal translucency as well as congenital heart defects. And again, non-invasive blood tests can determine if the baby's at risk. First trimester screening, looking at both ultrasound and the fetus, as well as blood markers, can be helpful in determining which babies may be affected. And as I said, the low-risk population has the most babies with Down syndrome, so the screening is needed not just in the high-risk population, but also the low. It doesn't matter how you get the extra copy of 21, the clinical features are similar. So this is an epicanthal fold. It's an actual fold here in the eyes. Often they have a single gap or a wide gap between the first and second toe. They can have a single palmar crease. They often have tongue thrusting. We talked about the thick nuchal fold. 50 to 75% will have a congenital heart defect, and they also have very low muscle tone, which causes eating problems. With the Robertsonian translocation, the recurrence risk of having a child with Down syndrome is increased. The recurrence risk to have a baby with Down syndrome through the routine, non-disjunction is about 1% in women under the age of 35. Over the age of 35, it's whatever the age risk is. There's a 15% risk if an individual has a translocation. And it's 100% if one of the parents has a 21-21 translocation, which is very rare. This was actually the first woman to ever have an amniocentesis. You can see she has 3 siblings. With Down syndrome, she is a carrier of a 14-21 translocation. Trisomy 13 is much more severe of a phenotype. It occurs in about 1 in 15,000 to 1 in 20,000 live births. Features include holoprosencephaly when the brain does not divide into 2 halves, microcephaly, cleft lip and palate, extra fingers or polydactyly, and very severe congenital heart defects. Most babies die within the first few weeks. Less than 10% make it to a month, and less than 1% make it to a year. And the vast majority are lost during the pregnancy. And here we have a karyotype with 3 copies of chromosome 13. Trisomy 18, or also known as Edwards syndrome, features include intrauterine growth retardation, a very small baby. These are rocker bottom feet, and this is a very specific feature of the overlapping fingers. I also want to point out these kind of simple ears. Most babies die before the age of 1. 90% die before the age of 1. Again, they have very severe congenital heart, cognitive delays and congenital heart defects. And here we have a karyotype. It's always nice when it's circled, with 3 copies of chromosome 18. Partial chromosome loss. So Cri-du-Chat syndrome, this was originally described in France. These babies have a very high pitch like cat cry, and it's caused by a very small deletion on the terminal end of chromosome 5. So they have microcephaly, growth deficiency, this high pitched cat-like cry, congenital heart defects, and low muscle tone. Most cases are sporadic. About 2% are a result of a balance rearrangement from one of the parents. And the larger the piece deleted, the more severe the phenotype. Again, the mental retardation, the cat cry is a little more proximal, speech issues. So the larger the piece, the more severe. Nowadays, we're going to talk in molecular cytogenetics about microarray. This is more used to look at this. 4P- or Wilp-Hirschhorn syndrome. They often describe this as a Greek helmet face. Cleft lip and palate with kind of this downturned fish-like mouth. Hypertelorism with this very broad nasal bridge. They have microcephaly and very severe cognitive delays. And again, the larger the piece, the more severe the delays. It's caused by deletion on the short arm of chromosome 4. And so, a baby is born full term with a birth weight of 4 pounds 10 ounces. She has multiple anomalies, including a cleft lip and palate, polydactyly, heart murmur. Chromosome results are consistent with the following clinical phenotype. 46 XX deletion 5P15.1, 47 XX plus 21, 47 XX plus 18, 47 XX plus 13, or 45X. And this concludes the lecture on clinical cytogenetics, part 1.